Thank you. That's a hard act to follow. What a great kid. Sorry, I got to do this. Okay, so I'm an epileptologist, and I also work in the fetal neonatal program at Boston Children's. And so my task for today is to talk about the current approach to epilepsy management across the SCN2A spectrum. And tomorrow we're going to talk about syndromes. So I'll touch on that briefly to put things in context. Nothing super relevant as far as disclosures. Our objectives are to talk about treatments for epilepsy, including medications, dietary approaches, surgical approaches, and then not going to go in depth into the trials. You're hearing about that otherwise, but we'll talk about the broad idea of clinical trials. So this is just a little preview. Tomorrow, if you come to, depending on which track you come to, I'll talk more about epilepsy syndromes. This is a very broad strokes approach to the different types of epilepsy across that we see in SCN2A with age of onset on the top. And you heard from Al George this morning that some newer work uses not this 0 to 3 month and 3 month and more, but breaking it more into the neonatal, which is the first month of life onset. Many of those are in the first week or couple weeks of life versus infantile onset or beyond. The self-limited epilepsies can happen anywhere in the first couple of years of life. And then DEE stands for developmental and epileptic encephalopathy, which is a term we use for children who have developmental impacts, both from the underlying disorder, in this case SCN2A variants, as well as the abnormal electrical activity and seizures. And then there are children who have epilepsy that don't fall in to any of those specific categories. So my first suggestion when thinking about how do you treat seizures for those families to whom this applies would be to establish your goals along with your family caretaker and epilepsy provider. Set those priorities and reset those priorities as things change. Is it reasonable for your child to expect seizure freedom? Do we need to adjust those goals? What are the seizure types or patterns that are really most negatively impacting? Are they falling asleep and not able to benefit from their therapies or school because they're postictal and missing everything? Is it that their sleep is mostly disrupted? And sort of figuring out where we're impairing quality of life can help you work with your team to target those symptoms as best we can. Not that we're perfect in our ability to treat, but as a team, we can do better. And look at the trade-off between reduction in seizures versus intolerable side effects. There is a lot of building data that polypharmacy is not necessarily better. Polypharmacy meaning multiple medications, or at least not continuing to add and add and add without trying to take something away. So this is just a schematic. I don't expect anybody to memorize this whatsoever, but kind of drugs that have been available over time. We do have a couple of more recently new ones. And as we've gained more medication options, we actually haven't turned the dial too much with regards to what percentage of patients are refractory. If you look at epilepsy overall, about a third of patients are refractory, meaning not responding to the first two appropriately chosen medications. The last two, cenobamate and fenfluramine, are a little bit interesting in that at least in certain populations, they seem to be having more of an impact, but no data on those specifically in SCN2A yet that I'm aware of. So this is a figure just showing you where different types of anti-seizure medications target. The green blob on top is a neuron or a brain cell. At the tip where it connects with another neuron, which is the yellow underneath and the kind of brown membrane. And you can see the sodium channel up on the side. Let me see. Oops. That didn't work. Sorry, I won't try to point, but there you can see Na means sodium, and there's the biggest box of names there are the more pure sodium channel blockers. So it's a channel in the membrane of the neuron or the brain cell that transmits sodium, and that helps manage the electrical activity and the release of neurotransmitters, which are essentially chemicals that help one cell talk to another cell. Some are excitatory, they make things more active. Some are inhibitory, they make things less active. And then there are other mechanisms that target other channels like the calcium and the potassium, and the balance of those can be important. And others target GABA, which is a negative inhibitory neurotransmitter or target receptors like AMPA that receive those excitatory neurotransmitters. So there's a bunch of mechanisms. Sodium channel blocking is the one you're going to hear about most at this conference because it most directly targets the problem if there's an increased function and the one that you want to avoid if there's a loss of function. So for the self-limited epilepsies, these are infants or at least in the first couple of years of life who have seizures otherwise seem to be developmentally normal. The EEGs are usually pretty benign. That's the electrodes you put on your head and test the electrical activity. And those kiddos tend to respond to almost anything we give them, whether or not they're even specifically targeting the problem. So phenytoin is a commonly used one. Oxcarbazepine is probably better tolerated if you're going to continue it for several months, but they respond to almost anything. And we tend to continue it for a few months, and then we'll try to wean off, and the developmental outcomes tend to be pretty good for that group. There is sort of an intermediate group, but then we get to this early infantile developmental and epileptic encephalopathy. That's that term that I mentioned to you. So early infantile, according to our seizure syndromes, is the first 3 months of life. But again, in SCN2A, many of the infants present in the first days of life if they have that pure gain of function picture, but it can present anywhere in infancy. So in that pure, very early onset picture, the sodium channel blockers seem to work best, but they might not be adequate. And so you might still see seizures. They just tend to work better than the others. And these are amongst the treatments that we often give for babies in the NICU anyway. There's thankfully increased awareness of if it's not a stroke, if it's not a bleed, it's likely genetic. And of the most common causes that we see in the NICU, SCN2A is one of them, that and KCNQ2, both of which respond to sodium channel blockers. So there's increased awareness and better use of these medications in the NICU for this spectrum. And this is just a little bit of data from that clinical trial readiness project that Al George presented on earlier on the parent caregiver rated good or excellent response to specific medications with neonatal onset seizures, but not everybody is in the neonatal period either. And if your sodium channel blocker isn't working, you can add another sodium channel blocker, but sometimes in epilepsy, we try to use other mechanisms too, even though if it's not specifically targeting the SCN2A channel, it can still help and may be better tolerated than adding on more and more sodium channel blockers. So this is just a list of many of the sodium channel blockers. Many of them work through decreasing the fast inactivation and the rapid firing. Lacosamide is one that targets the slow inactivation. So several of these can have slightly different mechanisms. Cenobamate might impact the persistent current. There's some data to suggest that, which is something that's targeted by many of the gain of function variants, but not all of them. And then we have medications that have mixed mechanisms that include sodium channel blocking. This is a picture that Ted Cubbins gave me of just showing the carbamazepine as an example of one of the anti-seizure medications as it binds in the inner pore of that voltage-gated sodium channel. Cenobamate, I mentioned, is one of our newer medications that seems to be having more of an impact than some of the others. The trials have all been in adult epilepsy, so it's not approved in pediatrics yet. There's a phase 1 trial ongoing, and we use a lot of things off label in pediatrics. So there's growing pediatric experience across, especially at academic centers. And so these are just a couple of studies that have reported on experience in pediatrics. And these are all patients who have been on other medications and not responding. And there is reasonably good response for an add-on medication. So what is our approach essentially when we think there may be a loss of function or a mixed picture? Certainly if we think it's a strict loss of function, and in some of the other situations where it's older onset, we're cautious about sodium channel blocking. And you'll hear from many families that if they tried a sodium channel blocker, it increased seizures. So we don't, as you have heard, we don't have electrophysiology on everyone, and also a cell is not a mini human, and so we still do need to look at the patient and how they're responding to treatments. And so we use our best judgment based on the clinical scenario, which often includes age of onset of epilepsy here, but can include other factors. The spasms are more common in later onset and mixed function, for example. And then we'd avoid sodium channel blockers in that situation, consider the other mechanisms that I mentioned, and non-medication options. So across that whole spectrum, whether you have gain of function, loss of function, mixed function, whichever epilepsy syndrome you have, if you're not responding to medications, it's important to talk to your doctors about what are the other options. So dietary options are amongst those. The classic is ketogenic diet, which is a diet that's very high in fat, very low in carbohydrate, and enough protein to maintain growth. It needs to be done in a dedicated program with a neurologist and a nutritionist working closely together. It's not something that you would ever do on your own. It works on a mechanism of ketosis, and it impacts inflammatory pathways, impacts metabolic pathways, it changes the microbiome. And so there's a number of different mechanisms by which it may work to reduce seizures, and it can reduce seizures even in those who are not responding to medications. The modified Atkins diet works on a similar mechanism of ketosis, but is a little bit more flexible and easier to maintain in patients who are eating orally a regular diet. And the low glycemic index diet is one other option that some centers will do. At Boston Children's, we do the first two, but they're all potential treatments for refractory epilepsy that you would want to consider. There are guidelines even for use in infancy. It can be done with breast milk, but not with exclusive breast milk. So it can be used across the spectrum. We're actually starting a clinical trial soon, looking at this as a potential prevention of epileptic spasms as well. There is some data to suggest that it's particularly beneficial in genetic epilepsies, and it's used as second line for epileptic spasms and then sometimes as first line, but we're going to be looking at it as potential prevention as well in genetic epilepsies. And then the third category of treatment for epilepsy are surgical treatments for epilepsy, which again are applicable across the SCN2A spectrum for children who are not responding to medications. There's not necessarily a specific order of you have to go to diet, then you have to go to surgery. Both of those categories should be discussed if medications aren't working. It's less likely that with an SCN2A, if that is truly the cause for the epilepsy, that you'd be a candidate for resective surgery, where we actually take out the portion of the brain causing seizures. If there's a malformation like a cortical malformation, and it seems like the seizures are all coming from there, that might be something that's considered even with a genetic diagnosis, but with caution that it's not likely to be curative. And the main malformation that's been associated in some individuals is polymicrogyria, which is usually more diffuse malformation in the brain. So these options that I show here are more palliative surgical options. So vagal nerve stimulator is a battery pack that goes under the skin at the top of the chest and a wire that connects to the vagus nerve in your neck. And that communicates with the brain back and forth. And so we send intermittent signals that can be programmed through the battery pack in the chest. And the couple that are newer to the field in pediatrics are deep brain stimulation and responsive neurostimulation, which are approaches where there are electrodes that are either on the surface or into the brain. So for deep brain stimulation, those electrodes go into nuclei in the thalamus. There are a couple different nuclei, the anterior nucleus of the thalamus or the centromedium nucleus of the thalamus, depending on whether it's more of a focal versus generalized epilepsy, that are targeted. And that sends intermittent signals. We can set the parameters and titrate over time, and it gives some feedback on what's happening with regards to seizures as well. And responsive neurostimulation, you can put at specific places on the surface of the cortex. That's probably less likely to be relevant because there aren't going to be specific foci here. It's going to be more diffuse, although there are some centers that actually use that and put them into the thalamus. So those are some palliative surgical options to consider, and we're gaining they're approved. I should say that the deep brain stimulation is only approved in adults, but we are gaining experience in pediatrics as well. And then if things are not getting you where you want to go, it's always a good idea too to think about what's coming next. That's why you're all one of the reasons you're all here too is to hear about the great science and what's coming next. But there are clinical trials that are applicable, and different ones may be applicable depending on the specific epilepsy situation, or some not specifically for epilepsy. And they fall in three broad categories that Dr. George outlined. Actually, Dr. Sanders outlined nicely this morning as well. So small molecules or drugs like those anti-seizure medications that we're already giving, that can have various different mechanisms of action. Antisense oligonucleotides target the RNA and are usually given through a lumbar puncture. And at this point, target gain of function variants, but they can be used in a variety of different ways. So there may be other approaches to using oligonucleotides down the line. And then there are other precision medication approaches like gene therapy and vector-based approaches that are coming. Last thing I wanted to just mention was seizure detection devices. There are more and more options for wearable devices, cameras, mattresses, and several of these have good data in the literature, and including seizure detection dogs. The challenge is that most of them have good data that they can detect generalized tonic-clonic seizures, full body stiffening or shaking, or the focal to full body stiffening and shaking. But they're not going to be as good at picking up a subtle seizure where you're staring, stop breathing, but you don't have that motor activity. That's still a limitation, and there is lots of literature into variables, so hopefully this will improve over time. But it's definitely something worth considering. There's data to suggest that we reduce SUDEP by having somebody in the same room. Whether those rates are truly, SUDEP is an unexpected death in epilepsy. Whether these actually reduce that risk is still a matter of something that's being figured out, but they can at least detect seizures and get people there to help. So that's my contact information. If you have specific questions, I'm around. Just find me.